Okay, we're going to go ahead and start on Unit 3. So this is Chapter 12. We finished our prenatal, we finished our labor and delivery. Now we're going into our postpartum portion of what we're going to talk about, postpartum and the babies and things like that. So starting with postpartum, what are some things that we're going to see with the postpartum mom? Hopefully I can get this to work. Okay, so what kind of maternal adaptations that are happening during that postpartum period? That's more physiological things. What's happening to their bodies during this particular stage? So if you're looking at data collection, that's going to be our assessment. So what are we actually doing with that assessment? Well, we're going to do something called, it doesn't have the HE on it, but we do something called bubble HE. And if you break that bubble HE down, the B stands for breast, the U stands for uterus, B stands for bowels, the other B is the bladder, the L is the lochia, the E is the episiotomy, and then HE stands for Hohenstein, which we're not really doing a whole lot anymore. We check clonus more than we do Hohenstein now, and the E stands for edema. So those are all the focus things that we're going to do when we go in. We're going to do a head to toe just like we would any other patient. Listen to their lungs, their heart, assess their neurological status, all the things that we're going to do. This is just where we're going to focus because they're a postpartum patient. So we're going to look at this bubble HE. So if you ever get stuck and you're thinking, okay, what do I need to talk to him about? Well, everything after that pregnancy is going to be changing. Things are going to be a little bit different. So we're going to have to really look and see what's going on with that mom. So, well, if I can get this to move again. Okay, so one of the things that we're going to look at, one of the big things we're going to look at is the uterus. That's where the baby was. So it's part of that reproductive system. It's an organ. It's going to return to its non-pre-pregnant state. And we call that process involution. So it involutes back down. So the uterus contracts and it involutes back down. And as it involutes back down, it seals off any blood vessels, which helps clamp down that uterus and decreases the lochia. So 1 hour after delivery, usually that fundus, that first hour after delivery, the fundus is going to go up just a little bit, probably a finger breadth over the umbilicus, and it's going to be very firm to palpation. If it's not firm, that's an abnormality that we will talk about in the next chapter. So, and we're going to look at that. Then after 24 hours, our fundus should be down 1 to 2 centimeters. So right after birth, it's going to rise a little bit. Then 24 hours, it's going to descend. So we're going to monitor that fundal height. It should descend 1 finger breadth every day until it goes below the pubic bone, which is usually about day 10 to 14. So this is what is normal. Sometimes you will get a mom that maybe gets, and we're going to talk about a subinvolution where the uterus doesn't go back down. This is normal. This is what is supposed to happen. So if you look at the next slide here, you can see where day 1, here it goes a little bit above the umbilicus right after delivery. And then 24 hours after, it's going to start involuting down, and that's the normal process of what should happen. So there are some things that can inhibit or kind of change the way that it goes down. Sometimes if you've got a mom that's had lots and lots of babies, that uterus just doesn't want to clamp down as much. If it doesn't clamp down as much and involute as much, they're going to have more potential for bleeding, infection, things like that. A boggy uterus, that just means the uterus is not firm. If a uterus is not firm, we're going to have to massage that uterus to make sure we really firm that uterus up. Otherwise, there could be more tendencies for some of those smaller little blood vessels to bleed. After pains with the uterus, feels a lot like contractions, and they'll say, oh my gosh, it feels just like contractions. Sometimes they can be pretty severe. Usually after the first baby, they're not quite as bad, but the more babies that they have, the more severe those after pains can be. They are increased with breastfeeding, and they might get really bad intensity. Sometimes the moms will complain not really of anything from delivery. They will complain about the contractions when they're breastfeeding, so they will take pain medication for that. That's why we have to do our fundal checks. So when we do our fundal checks, you always have to I always put my dominant hand at the bottom of their uterus because you want to hold that lower section of the uterus, and then I put the top hand at the top and then kind of just push down to feel. You always want to put your hand on that lower segment and hold it, because the cervix is open and you could actually push that uterus out that cervix. So we always want to make sure that we're holding onto that cervix. Lochia is going to be very common. For the first few days, it's going to be that rubra. So it's going to be bright red. It's going to look like a menstrual period. And then after about day 4, it should start getting more pinkishy, kind of brownishy. We're going to call that lochia cirrhosis. So you think more of a cirrus kind of thing, more of a pinky brown. That's going to last till about day 10. Then we're going to go to lochia alba, and alba just means white. So it's going to kind of go to a yellowish, creamy white kind of color about 10 to 6 weeks. Now, this is something that you're going to want to educate your moms on. If they start getting lochia and after day 3 or 4, they've still got lots and lots of bleeding, maybe there's a smell to it, their uterus just doesn't seem to be going down, those are things that they need to be reported to their physician. There could be an infection, there could be a subinvolution, there could be retained placental parts, there could be a bunch of things going on inside there that needs to be definitely looked at before we can go any further. So how do we know how much is too much lochia? So when our moms come back, sometimes our moms get very panicky sometimes right after they've had that baby, because they will come in like, oh my gosh, it's dripping down my legs. That's a lot of times that's normal. So we kind of define it as being scant, light, moderate, heavy, excessive blood loss. So the big kind of thing that we want to look at here is the hemorrhage portion. If you've got a mom that is fully saturating a pad in 15 minutes or less, that's excessive blood loss. That needs to be reported to your doctor. You're going to have to massage that uterus. If the rule up there on the unit is if they saturate one pad in an hour, that's too much. So we need to let someone know about that. That's why it's important that they make sure they put those pads on. And if they think they're bleeding excessively, go ahead and give us a call. Let us take a look at that pad and make sure that it's not more than what it looks like it should be. Many times after a C-section, you're going to see less lochia, because when they go in and do their C-section, they remove the baby, they remove the placenta, and they also kind of scrape out that uterus. So there's really nothing left to come out. So they have minimal lochia after a C-section. So you might not have a lot of discharge after a C-section. Now, as far as ovaries, when's my ovaries going to start to work? Well, actually, your ovaries can start to work within about 3 weeks after delivery. So if you're not taking anything, you're not breastfeeding, there's always that potential that you could ovulate. You might not even know you're ovulating. And then the next thing you know, you are pregnant again and you've got Irish twins. So you always want to make sure that there's some form of protection, and usually your provider is going to talk to you about that before you go home. Usually your menstrual cycles will begin within 6 to 8 weeks if you're not breastfeeding. If you're breastfeeding, typically those menstrual cycles won't stop until you're getting close to stopping your breastfeeding. So if you breastfeed till 18 months, they may not have one for 18 months. If you breastfeed 2 years, you might not have one for 2 years. Sometimes though, as the baby takes more table food and they're taking less breast milk, that your body will start to go back to a normal thing. So you may have your first period in a year or so. So, we want to make sure we're really talking to them about, protection. And if they don't want another baby, we need to make sure we're talking about that. So what does the cervix look after a mom has had a baby? So after the baby, usually this cervix looks just like this before they've had delivery. After they've had delivery, the cervix will always have a slit-like appearance, and it will never completely go back to where it was after dilation. So that's important to just let them know. So what's the vaginal canal going to look like? What's the perineum going to look like? Well, sometimes the vaginal area can have some small little tears, and it can be kind of smooth. Muscle tone in that vaginal area probably will never ever go back to the way it was prior to delivering a baby, but you can get a lot of that muscle tone back. So we tell moms to really start doing Kegel exercises to try to restore that. So, squeeze the butt cheeks and release, and squeeze and release. The vaginal rugae will return in about 3 weeks, because remember that vaginal canal has been stretched out, so that rugae has been stretched out. After about 3 weeks, all that's going to come back to be of a normal appearing, normal feeling kind of rugae. If an episiotomy is done, you're going to have sutures. Most of the time, those sutures are absorbable. So most of the time, we're just going to tell that mom to make sure that we keep it clean and dry. That means no bathtub baths or anything. And a lot of times, they won't want you to take a bathtub bath for several weeks afterwards, just so you're not sitting in contaminated water and there's a chance for that episiotomy to get infection. They will also tell you to make sure you change your pad very frequently, so that blood, that warm, moist blood, does not sit there and have the potential to develop an infection. Okay, so moving to breast. The first stuff that's going to come out is called colostrum. It is where it's very, very rich in antibodies, and it's the first milk that is going to be secreted by the breast tissue. It is probably the most important that gets given to the baby because it has all of those antibodies that mom has that she's going to passively give to the baby, so the baby can have protection of anything mom's protected against, baby will be protected against. Now, a lot of times right after delivery, the doctors will say, let them go ahead and start breastfeeding. They will get a little bit of colostrum, which will have some fat. It will have a lot of sugar in it, so it'll keep their blood sugars up. Most of the time, the babies can keep their blood sugars up unless they had lots of stress during delivery or mom was a gestational diabetic or something like that. But the more that baby suckles, the more it's going to tell the brain to release prolactin, which is going to start that lactation process. So usually their milk's going to come in about that 3rd day. So when they're with us, the milk hasn't came in yet. Breastfeeding's probably going really great right now because nothing's really happened yet. Once that milk comes in, that's when it gets very, very difficult. Sometimes breastfeeding can be very hard. It can be very painful. So there's a lot of things that go into that. So a lot of teaching needs to be done before they go home so they can anticipate what's going to happen afterwards. Okay, so what's going to happen to my cardiovascular system? We know that when we get pregnant, we have an increase in that, the vasculature, we have an increase in our blood volume. So after delivery, we're going to have a loss of that fluid volume after delivery, just the baby, the placenta, the fluid volume, and then your body's going to diurese and get rid of a lot of the extra fluids that you have. So sometimes we can get like a hemoconcentration that results in our hematocrit looks elevated when it's really not elevated because of this fluid loss and that hemoconcentration that we get. So we always want to make sure we look at the blood levels and look at all of the hemoglobin, hematocrit, all of that kind of stuff in a contextual way. There's other changes that are going to happen as far as like our plasma fibrinogen, our white blood cell count. So a lot of times our coagulation factors are going to be elevated, so our clotting factors are going to be elevated, which is going to predispose that mom to potential for thrombophlebitis. So get them up and ambulate. Use the SCDs if they've had a C-section. Make sure they're doing the foot pumping. Make sure that they're moving their legs around. White blood cell is also going to be elevated. It's the body's response to inflammation, and it protects our bodies against any types of infection. So it's not uncommon to see a white blood cell count 15 to 20,000. Now, if you see a mom, though, that has a white blood cell count of 20,000, she also has a fever, that may clue you in that there may be more of an infection than more of just a physiological something that's happened to mom. So just keep that in mind. As far as vital signs, usually, sometimes you might get a little bit of elevated temperature, but we really don't see any increased temperatures unless we have some type of infection. Right after delivery, a lot of times the pulse will go down a little bit. It may be a little bit slower than what it had been. Blood pressure. It's going to be elevated if they have preeclampsia. Just because we delivered the baby, that is the cure for preeclampsia, but it doesn't mean that preeclampsia is gone. Sometimes moms will actually develop that severe preeclampsia after the delivery. So they're not out of the woods once they've delivered the baby if they have preeclampsia. Sometimes that can come back and they can become very ill, and this is where they can be very serious. If they have a decreasing blood pressure, that could be thinking of hemorrhage. If they have an elevated pulse, that's one of the first things we're going to look at as far as hemorrhaging. Okay. So Other things that you're going to look at is the musculoskeletal system. So their abdominal muscles are going to be very, very weak because they've been stretched. They've got that diastasis recti abdominis, which means that those abdominal muscles have separated during pregnancy. So the muscles actually separate, and you can almost put your hand through those. The only thing that you can really do to help with that is exercise. They will tell you for the first 6 to 8 weeks to kind of refrain from any exercise like that or any pressure, especially if you've had any kind of C-section, anything like that. But after 6 to 8 weeks, they will tell you that you can start back an exercise routine, start to try to tighten those muscles up. They do tighten on their own, but it does take a lot of work to get those down. As far as the GI system, once moms have delivered the baby, a lot of times they are starving because one, we haven't really allowed them to have any food. We've given them all the sugar that they've needed through their IVs, but they haven't really gotten that GI tract going. So they're going to be very hungry. Constipation may be a problem just because of delivery, and the baby's gone now, so the colon has to go back to its normal positions. So there's going to be position changes in there that's going to be occurring. If they've had a C-section, they've had major abdominal surgery, so that's going to make a difference. So there's a lot of things. They're not going to be as active as they were, so constipation's always going to be a big problem during that last stage. As far as urinary system, we're going to have a little bit of diuresing where they're going to excrete a lot of the extra blood volume that was inside our bodies. So we're going to be getting rid of that. We can get some damage to our bladder during that birthing process. Sometimes mom will have a temporary or loss of bladder sensation, especially if they've had a spinal or they've had an epidural. So we have to be watching for that. So anytime moms has had an epidural or spinal, they have to urinate within 6 hours. If they don't, we usually will look at the bladder scan to see where they are. If they still can't go, we're probably going to have to do like intermittent catheterization just to make sure that we get that urine out of there. We don't want any urine stasis that could potentiate an infection. So we want to look for those kinds of things and make sure that the moms are getting up and urinating. A lot of times moms get a little bit nervous about going to the bathroom for the first time just because it's going to burn, and a lot of times it does burn, especially if they've had an episiotomy. It will burn a little bit. So we always want to talk to them about those kinds of things. Also, if they have a full bladder, it increases their risk for hemorrhage. So we always want to make sure that bladder is empty. So we want to encourage them to get up frequently. One, it helps prevent DVTs, and two, it helps prevent urinary tract infections, and it helps prevent any types of postpartum hemorrhage. So there's a lot of good things in that. The integumentary system, again, we're going to have that diaphoresis where they're going to be sweating. They're going to have those night sweats. And then the striata, which is just the stretch marks, those are going to kind of be kind of pink initially. They will fade to kind of a silvery color, but they really will never go away. Now, the linea nigra, that is the line, the brown line that goes from the belly button or the top of the belly button all the way down to the pubic bone. It's just a little line that goes down the center. That comes because of the hormonal changes, and that will go away. As the maternal hormones go back to normal, that will go away also. As far as weight loss, a lot of moms right after delivery, they're going to lose about 12 to 14 pounds right at delivery because you think about the baby, the placenta, and the amniotic fluid, and the diuresing. They will lose that 12 to 14 pounds. The additional 5 to 15 pounds is usually going to lose that in the early postpartum period. But we usually tell moms it takes about 6 weeks for them to get down to their pre-pregnancy weight because you've gained 25 to 35 pounds if you've gained the recommended weight. So if you've gained the recommended weight, we tell moms about 6 weeks, 6 months is where you should be back down to your pre-pregnant weight. If you gain more than what the standard 25 to 35 pounds was, you may say you've gained 50. It may take you a year to get some of that weight off from baby weight. Now, breastfeeding will help lose weight. It increases weight loss much faster. So moms that are breastfeeding need about 500 calories a day to sustain them and the baby. So a lot of moms will see the increased weight loss right after if they are breastfeeding. Psychological. So we talked about physiological, that's things that are happening to the body. What about psychologically? There's a lot of things happening psychologically, especially if it's their first baby. but they've got a role change now. They've gone from maybe no kids and having their own lives to now I have this very dependent human being that I've got to care for 24 hours a day. And so that's going to be a big role change for them. So I would do more talking about this with our first time moms, because if they've had a baby before, they're going to anticipate what's going to happen when they go home. But every child's going to be a little unique. Your first baby might have slept from the first night on. This baby may is up every hour. So there's a lot of changes that every baby's going to be a little bit different. And it's not just mom, it's siblings, it's families, it's significant others, all that's going to change. So we need to be very instrumental on helping them understand what's going to be happening in their families when they come home. So as far as being a mom, when we think about psychological, one of the things that helps us is it's 9 months. So we have certain stages. We've had a whole 9 months to get prepared, but we start that beginning attachment to that baby. We've prepared for that baby all through pregnancy. We've increased that attachment as we've been pregnant, and now we're learning to care for our baby. We're trying to do that physical restoration during that early postpartum period. We're going to try to move to a new normal. That's why, it's important that moms take the time that they need from work or from whatever to get used to having the new baby, because it's a lot of additional responsibility. It's a lot of additional things, and they've got to move now to what is my new normal, whether it's with my first time mom or whether it's a mom of 3 and she's added that third child to it, and she's got to move on to where my new normal is going to be. It's not here anymore, it's going to be here. So they have to learn about that. Usually most of our moms can get back to their normal identity about 4 months after the baby's born. So that first 4 months is just basically just taking care of another human being, and if they have other children, taking care of them also. And the moms kind of don't really have that identity anymore because this is their identity. So by about 4 months, they're starting to, okay, now I'm kind of coming into myself again. I kind of know where I'm at, what my identity looks like again, and where I've been. So positive family relationships, attachment's going to be a big thing. We need that bond to happen between parents and the infant. So it's something that we want to watch. And so we document that every 4 hours while the babies are with moms and significant others to make sure that that bonding process is happening, because if it doesn't, we need to get social services involved, because sometimes we have poor outcomes if baby goes home and there hasn't been an attachment that has been taking place. Sometimes bonding takes a little bit longer. Sometimes people have that immediate bonding. So it's a process. Some moms aren't really bonded in the beginning, but as time wears on, they begin to bond, and the bonding is fine. It's just everybody is going to bond in a different way. No way is right or wrong, but now if they're not bonding at all, that's going to be something that we need to get somebody else involved. So look at how mom is interacting with the baby, how the significant other, are they talking about it in face? Are they calling it sweet baby and all these things, or are they not wanting to change their diaper? They're not wanting to look at it. They don't want to feed it. They want it out at the nurse's station. So look for those kinds of things. Also let them know when they have little tiny siblings that sometimes we have to watch that too, because sometimes those siblings aren't always as nice to the new babies as they could be. So still with the psychological, it's normal to have all of those things, but then we come into something that's just called the postpartum blues. It's very, very normal for moms to kind of feel just kind of tearful, kind of sad, overwhelmed, grouchy, not really sure what's going on. Maybe they're not, I just can't think. I don't even know what I need to do next. I can't prioritize anything anymore. This is usually temporary. It says it lasts 2 to 3 days, but I think it lasts more, about a little longer than that, about 7 to 14 days. But it's temporary. It does go away. It just lasts, that usually it will develop within that first 3 to 4 days after the baby's been born, and it will last about 2 weeks. Be aware of your cultural differences. Sometimes those people will not let us know what's going on, so we have to ask those appropriate questions. Sometimes the postpartum blues can actually lead into a postpartum depression. If that happens, that's a medical emergency. Every mom is given a survey before they leave on depression. If they answer the depression scale at a certain level, it automatically clues in social service to come and talk to them and see what's going on with them. Where are you going home? What's going on at home? What's happening that maybe we need to talk to the doctor about some medications, what's going on there. So we always do that postpartum assessment. A lot of these moms are going to go home very early, so that's why it's very essential to detect this stuff before they leave. So data collect, get that survey done, make sure you're interacting with that mom. We usually do assessments every 4 hours, so you're going to be in there at least every 4 hours looking at that mom. While you're in there, talk to her, look at those kinds of things. And, we're going to do the bubble heat, we're going to do all that kind of stuff as we're in there. Okay, so kind of moving about our assessment, looking at what are we going to do every time we go into the room. So our initial physical findings, that very first hour after delivery, what is the main things we're going to look for? 1, hemorrhage. So we're going to treat that hemorrhage. We're going to treat the pain. We're going to ask them what their pain is, a scale from 1 to 10. Or if you're using the smiles, what is that? Faces, what is your pain? We're going to make sure we're preventing any type of infection. Keep them clean, keep them dry. Make sure that they're going to the bathroom. Make sure we're all washing our hands. Make sure we're wearing gloves when it's appropriate to wear gloves. Make sure we're using the right types of things on our moms and everything is cleaned before we bring it into the rooms. Preventing falls. If they've had a C-section and they've had a spinal or they've had an epidural, these moms are not going to be able to walk. Some of them think that they can, and we did have an instance where the nurses were telling us that right after one of the moms had a baby, she tried to get up and she had fell. So preventing those falls, we don't want anybody to get hurt right afterwards, and they may feel like they can walk, but their body just has not gotten that neurological feeling back yet. We want to detect and make sure we treat any urinary retention. So after that catheter's been pulled, or after that baby's been born, within 6 hours, they need to urinate. If they don't, we have to check and see if there's fluid. I guarantee there's fluid because they've been pumped full of lots of fluid, so there's going to be fluids. A lot of times they might not be able to feel it because that epidural, that spinal hasn't worn off yet. So if they can't and they're not able to go, we're going to have to do a straight cath to make sure that we keep that bladder non-distended to help with that hemorrhaging. Prevent constipation, increase their fluids, increase their fibers. They may need a stool softener, something that the doctor can order to help with that. Preventing and detecting that thrombus formation, making sure that they're moving their legs. If they've had a C-section, they need to have SCDs on while they're in bed. Get up and move. Like a lot of times our moms will have a C-section that morning and they're up that afternoon. Get them up and moving. Use that abdominal binder that will help tuck everything in and help them to get up a little bit better. But have them do leg pumps, make sure they're moving their ankles in circles, promoting sleep. So helping them to get a good night's sleep. Let them rest when the baby's resting. So try to cluster your care. Try to go in there and get everything done that needs to be done right away. So then that when baby's sleeping, mom can be sleeping, even if it's 2 o'clock in the afternoon. Allow them to sleep. They may have been up through the night. They may have had a lot of things happening. So help them promote that sleep. Help them promote that attachment. Make sure that they're feeding the baby. Make sure they're waking the baby up. Make sure they're changing the diapers. If they want to help with the bath, make sure they're doing those things. Make sure they're engaging in the care of the baby. Okay, so we've kind of already talked about our postpartum assessment. So we've done our bubble here. We've kind of talked about it. But what are we going to look for? So when we look at the breast, we're going to look for redness, we're going to look for cracks, we're going to look for any painful areas, we're going to look for inverted nipples, we're going to look for erect nipples, we're going to look for engorgement. If the baby's not latching really good, maybe their nipples are inverted, they may need a nipple shield, something to help the baby be able to latch. We're going to look at the uterus. Make sure the bladder is empty. So we might want to have them get up and go to the restroom before we actually check, and then we can check when they get back. To check that, we want to make sure they're in supine position. We're going to check the tone of the uterus. We're going to check the position of the uterus. We're going to check the height of the uterus. So all of that needs to be checked. If they've had a cesarean, we're going to check that incision. Is there any additional bleeding coming out of there? We're going to look at lochia. We're going to roll them over. We're going to look underneath them, make sure nothing has been pooling. A lot of times when we do that fundal check, they will say, oh gosh, I felt a whole bunch of bleeding out of there. So that's not unusual, because when they're laying there, that blood is pooling inside there, and when we push on it, we push that blood out. So it's not uncommon for that to happen. Just remember, 1 full pad an hour. 1 full pad an hour is what we're going to be looking for. And we're looking for golf ball size clots, not little clots. We're looking for golf ball size clots. That's what we're going to be getting more concerned about if they have those. And bladder, make sure that they're urinating frequently. Keep that bladder undistended. We may have to do straight casts if we have to, but we just want to prevent any type of infection. Bowels, make sure you're auscultating bowel sounds. If you got a mom that just had a C-section, they've manipulated those bowels and things in there. So make sure that we're hearing bowel sounds. If you don't hear bowel sounds, or mom's complaining of nausea, don't give her anything to eat. Give her ice chips until we know that she can tolerate that before we put food on top of that. So just make sure that we're talking to them about that. Some moms are afraid to eat because they're afraid they're going to get constipated. So make sure we're increasing those fluids. Make sure they're getting up and walking. Making sure we're getting enough fiber. Talk to the doctor about getting some stool softeners in there for them. As far as the perineum, we're going to look at the perineum, especially if they've had a C-section. We're going to look for any redness, any edema, any any bruising to like one side where we might have a hematoma. We're going to look at that episiotomy. We're going to look at hemorrhoids, anything that is going to be down there that we need to know that we're going to have to document. I know sometimes it gets a little bit embarrassing to do that, or some of the moms get very embarrassed to do that, but the nurses up there do this every day. And if we don't look, that's the mom that's going to hemorrhage, and we're going to miss a hemorrhage because we were embarrassed or we didn't want to look. So always make sure that you're looking. You don't want to miss something like that. Lower extremities, we're always going to want to check our pulses in all 4 extremities, not just radial, not just pedal. We're going to check them in all 4. We're going to look at capillary refill. We're going to look at clonus, so we're going to look at that. Any pain, any warm redness, tenderness in the backs of their calves, get them up and going. Make sure they're using their compression devices if they are in bed. Preventing their injuries. Have them sit on the side of the bed for a few minutes. Let their blood pressure stabilize. Otherwise, they might be a little bit hypotensive from all the fluid. And when they stand up, they've had a lot of vasodilation. They stand up and boom, everything just kind of goes out. So just make sure that I'm aware of that. If they get up to take a shower for the first time, make sure someone's in there with them for the first time. First bathroom, make sure someone's in there that they can walk them to the bathroom. Pain, we're going to use our PQRST. So we're going to look at where did it come from? What are the characteristics? Is it throbbing? Is it piercing? Is it stabbing? Is it intermittent? Is it continually? Does it come only with breastfeeding? Does it only bother them when they're walking? What is happening with them? What kind of comfort measures can we do outside of pharmacological? Positioning, ice packs, warm packs, cold packs, tucks, lidocaine spray, anything like that we can help with some of that. A lot of times after a vaginal delivery, they will rotate Tylenol and Motrin every 6 hours so that mom will get Tylenol and Motrin at the same time. I guess there's been some evidence-based studies that have said that if you give Tylenol and Motrin at the same time, they accentuate each other and actually give a better pain relief. So a lot of times you'll find doctors giving those together. Breast pain, make sure, is the pain bilateral? Is it unilateral? If we got unilateral and we have like a real warm spot on there, we could have something like a mastitis. So we want to look at that. Are they breastfeeding or bottle feeding? If they're breastfeeding, make sure you look at their nipples. Is there any nipple damage? Is there any suck blisters? Is there any cracks? Anything like that? So after pains, we said those breastfeeding moms will get a lot of those after pains. Sometimes they feel like really bad contractions. Usually we'll give ibuprofen for that. That's an NSAID. And what that does, it's a prostaglandin inhibitor. So when they suck like that, those prostaglandins are released, and that's what actually causes the pain. So an NSAID is a prostaglandin inhibitor, and it inhibits those prostaglandins, so stops them from happening. So when it stops the prostaglandins, we don't have as much pain. All those kinds of things. So we might want to time the time that we give their ibuprofen at the time that they're going to breastfeed. Maybe 45 minutes before they breastfeed, we give them their ibuprofen. Perineal checks, we're always going to make sure we're looking for any hematomas down there, any infection, any foul-smelling discharge, any severe redness, any swelling, zits baths, anything that we can do to help with some of that pain. Cesarean pain, usually the anesthesiologist is going to manage their pain for the first 24 hours, and then we will start doing that afterwards. I don't see a lot of PCA pumps up there anymore. We used to have a lot of PCA pumps. We do the epidurals. They can usually use their button for that. But as far as afterwards, we don't use that a lot. So a lot of the moms are going to get Toradol for the first 12 hours after delivery, and then they will go on to Motrin. Sometimes they will give Roxy or OxyContin. So it just depends on the patient. It depends on what physician that you have. So a lot of times your Roxy or your OxyContin is going to be PRN. It will not be routinely. But your Tylenol Motrin will be routinely. So, okay, so lab studies, what are we going to look at as far as labs? We're going to look at the hemoglobin hematocrit. So we're going to look at how much red blood cells do they have as far as their volume. And we're going to look at the hemoglobin. That's what's going to carry our oxygen. So if we have a really low hemoglobin, our moms aren't going to get the oxygen. So they're going to be very fatigued. They're going to be pale. They're going to have shortness of breath. They're going to have all those kinds of things. We're going to look at the blood type and the RH factor. If mom is RH negative and baby's RH positive, mom has to have that ROGAM-D within that first 72 hours after delivery. Rubella. If mom is not immune, mom needs to get the rubella immunization before she's discharged home. Again, we talked about bonding again, but bonding is going to be very, very, very important. So just always make sure that you're checking the bonding, and we need to be documenting that bond in the chart. So as far as mom's emotional status, we're going to look at like her mood and her affect. And you're going to find some people that just have very flat affects. They're just very kind of emotionless. So that's something that you want to always look for. Is this the way they always are? Is this a new feature? What's going on with this mom that could maybe be potentiating something? Reinforce any concerns about postpartum depression, if they're feeling very, not feeling well, if they're feeling, like they want to hurt themselves or they want to hurt their baby. Those are all things that needs to be assessed like right now. Try to get them back to a restful sleep, because sometimes if they're sleeping better, their emotional status will be better. So we want to talk to them about that, make sure they're getting all those kinds of things. So we're going to prepare them for discharge. So we're actually starting to prepare their discharge the moment they walk to the door to have the baby. But it's going to really start about teaching them how to take care of themselves and how do I take care of this baby. When does the baby need to eat? When do I need to do this? What do I need to do? How do I do this? Watch for anything that might not be a positive thing. Kind of determine where your mom's knowledge status is. What does she know and what she don't know? Sometimes you'll have moms that come in and they're having their third baby, but they still really don't know a lot about how to care. They know how to do certain things, but there's still more things that, well, I've had all, they might say, I've had, this is my third baby and I'm going to have them sleep on their belly. I always put, a stuffed animal in their crib. Well, I always put a blanket over the top of them. Well, that may be the case, but this may be the time when the baby doesn't do well with that. So we want to teach everybody the same stuff, making sure that they understand how to do certain things. So everybody's educated when they go home. So reinforce a lot of those positive behaviors, especially if mom's doing real good. Oh, you're doing so great. Let them know how good they're doing, because that makes them feel good. Sometimes as a new mom, you really don't know if you're doing okay or not. You don't really have anything to judge by. So just give them that positive support. Safety. Safety is very, very important. Make sure that the moms are doing what you're asking them to do. Especially with baby in the sleep. No stuffed animals. They're only swaddled. There's no extra blankets in the bed. They're not sleeping with the baby. They're not sleeping with the baby in the bed with them. All of those kinds of things are going to be very, very important. Let the parents know they need to be letting the children know at home what to expect when they get home. Because, a lot of times these kids will kind of have some aggression. They may go back to wanting a pacifier again. They may go back to wetting their pants again or wetting the bed. Normal things for children at home. Okay, now these are the things that you want to make sure that you tell them to call the provider in. So a lot of times we don't want to run in there right after mom's had a 48-hour labor and she's exhausted and start rattling off all these things that they have to do. So give them short information frequently and multiple times. So when you go in there, you might say, oh, the new studies have shown we're not going to do this with the baby, we're going to do this. Great. But mom probably didn't get it that time. So we're going to tell her it again the next time. And we're going to tell her it again the next time. Over time, she will start to hear what you're saying and start to really think about what you're talking about. So just keep that in mind, that make sure you're reinforcing that teaching, and you may have to tell things 3 and 4 times before it actually sinks in. So moms need to be told if they have a temperature over 100.4 or greater, they need to let the physician know. If they have any shaking or chills, any localized redness, painful areas on one breast. Usually mastitis does not happen in both. It's usually just in one. Any frequency, urgency, painful with urination needs to be told. Any sudden onset of shortness of breath or chest pain. We're going to be looking at our pulmonary embolus from maybe a detached DVT. So, also call the provider if they have any severe unrelenting abdominal or back pain. That's not being taken care of by normal measures. So if you are resting and you're sitting up with some pillows and you're taking some Tylenol and the pain's relieved, then that's okay. But if you've got severe pain and you've taken all the Motrin and Tylenol you can take and you've used every pillow in your house to help support and you're not getting relief, that's abnormal. So make sure that they understand that any unrelieved pain after you've used all these measures is not working, they need to call their physician. Any foul-smelling lochia, any increase in heavy lochia or lots of clots, any return to rubra after they've had serosa or alba, any severe pain, redness, or swelling in the episiotomy or incision site, swollen, red, and painful areas on the calf. Any of those things need to be reported to the doctor. And you will find, as nurses, we preach this to you in almost everything that we talk about as far as DVTs. We talk about UTIs, we talk about all this stuff. So a lot of times for us, this becomes second nature and we just assume everybody else understands it too, but they don't. They don't understand that urinary frequency or urinary this is an abnormality. They don't know, well, it smells funny, but I didn't really think anything of it. Or I think it's supposed to be heavy. Even though I've had this lighter flow, I just had a baby, so I'm sure it's going to be heavy. Let them know that that's not what should be happening, so that they're aware that they don't let something go that needs to be dealt with. So if they have any prolonged or severe symptoms of depression, and this is very important, they need to call their provider. If they have any signs of suicidal thoughts, suicidal ideations, any homicidal thoughts, infanticidal thoughts, that has to be reported to their physician like today, because sometimes that's going to be an inpatient and we've got to get that under control. So make sure that we get that done for those moms and parents. Breast care, just make sure that moms are cleaning the breast with just plain water. They don't need to use soap. They don't need to use anything else, just plain water. They can use lanolin cream. They can rub a drop of breast milk onto each nipple, let it dry because that has healing properties in it. So all of those things they can use. If they're breastfeeding and they get engorged, they could go ahead and pump a little bit off. Just know that if they pump a little bit off, they can save it. But if they pump a little bit off, their body says, oh, I think we need to make more. So it's a continuous kind of process. So that first to 6 to 8 weeks, sometimes the mom's bodies really doesn't know if they're feeding one baby or if they're feeding 6. So we produce lots and lots of extra milk. So that's a good time for moms to really stock up because they're going to be pumping a lot and they get engorged and it's very uncomfortable. Sometimes they can use what we call a haka. It just attaches with like a negative pressure on there and it just pulls the extra breast milk off. Sometimes they can stand in front of a warm shower and it'll help release some of that breast milk out of there and just make it more tolerable. You don't want to pump too much, but yet you don't want to not be comfortable. Or sometimes if you're really full, the baby can't latch because you're so full, you have to pump some off before the baby can actually get a hold of it. Just remember, if you're bottle feeding, We don't want them to express any milk. Yes, it's going to be uncomfortable. Yes, it's going to hurt for a while. But eventually, if you don't pump anything off, the brain goes, oh, I don't need to produce anymore because they have some. And eventually it will stop producing any milk. But if they keep pumping off, the brain keeps saying, I need more. So if they're not breastfeeding, we tell them not to do that. They can use cold packs. They can use cabbage leaves under their bras, and sometimes that will help. They need to wear a very, very good supporting bra. That bra has to support them because the breasts are going to get very heavy. They're going to get engorged. They're going to be painful because they're going to be, loose. So make sure we're doing that. So make sure you teach them all those kinds of things. Fundal massage, we're going to be in there every 4 hours doing a fundal massage. So until they go home, we're going to be doing that. As far as perineum and vaginal care, we have a peri bottle, and we tell them to take this home with them. You can put warm water in it and just put plain water, and instead of wiping with tissue, because that can be kind of irritating, just spray with the spray bottle. So make sure they wash their hands after they've handled the peri pads. That way they don't spread any infection to anybody else. Do not use any tampons or douches until they've spoken with their doctor at their 6-week checkup. No sexual intercourse until they've seen the doctor, and no birth control until they've seen the doctor. So all those are just important things that we need to let them know. As far as pain management goes, I usually tell moms kind of that first few days, take the pain medication routinely. It's easier to keep the pain at a 3 or get it down to a 3 than it is to let your pain get to an 8 and then try to get it down to a 3. So if we can keep it continually at a 3 or 4, that's a lot better than going all the way up to 9 or 10 and then having to get back to a 2 or a 3. So make sure that they take their medication as prescribed. And then other non-medicinal kind of things, just like ice packs, the Zitz Bass, the Americane sprays, anything that can help with some of that pain. As far as nutrition, we need to talk to them about, diets and certain food groups, just like we do everything else. If mom is breastfeeding, she does need to increase her caloric intake by about 500 calories a day. Constipation, encourage activity. If you get up and move, the peristalsis happens and they are more apt to have bowel movements. Encourage non-caffeinated fluid intake. If they drink caffeine, caffeine can cause some constipation issues, and it does irritate that colon lining. So we want to make sure we tell them to avoid any type of caffeinated beverages. If they use medication, I would talk to my doctor first, especially if they're breastfeeding, but I know that Colace or Docalox is very safe, and so they usually give them a stool softener before they go home. Moms need lots of rest when they get home. So if baby's sleeping, mom needs to try to be sleeping. We got to make sure mom stays healthy so baby can stay healthy. So those are all kind of important things that we need to let know our moms. And that's the end of our normal postpartum moms.